Good morning. Welcome to this virtual celebration of the 10th anniversary of the Affordable Care Act. My name is Tim Westmoreland. I'm a professor at Georgetown Law School, and I'm also joined today by Katie Keith, who's on the faculty at Georgetown Law School, at Georgetown School of Public Policy, the McCourt School, and is also, most prominently, the legal affairs correspondent for Health Affairs. So I'm delighted to have Katie here, and I'm happy to be here with everyone. So what we're going to do today is to start with a little bit of a discussion of the topic of the times, which is how the Affordable Care Act is helping the response to the coronavirus. But then we're going to go back and do what we had always intended to do, which is to celebrate that the Affordable Care Act is here, talk a little bit about its basic components, and then talk a little bit about what's left to do. So, Katie, let's start with the Affordable Care Act and coronavirus and how you think that the ACA does or does not help the nation respond.
Sure. An easy question, Tim. And thank you for having me this morning. It's great to see you virtually, and I'm glad we're able to have this conversation today. As we reflect on the sort of 10 years of the ACA and thinking about the sort of public health crisis moment we find ourselves in, I think it is a real moment of reckoning. The Affordable Care Act, I think, like any law, is not perfect and certainly has some of its gaps, some of which are being laid bare by the crisis right now. However, I think it is undisputable that the changes made by the ACA have really strengthened the safety net system, and we would be in a much worse place trying to fight the coronavirus battle that we're all facing right now without the Affordable Care Act. So when we think about the contribution of the ACA to the current moment that we're in, I think about 20 million people who have health insurance and expanded Medicaid programs that have helped keep rural hospitals open, access to preventive care and essential health benefits, and then even for those who get sick and have private health insurance, a cap on the financial liability that they would face. They're not going to have to pay so much more in out-of-pocket costs, and we'll have financial security as a result of that. So those are some of the things that come to mind for me. Of course, the law is incredibly big and touched really every facet of the healthcare system. So there's a lot more to say about that. But when we're thinking about a public health crisis, I think strengthening the safety net, having a functional individual market, and dramatically expanding Medicaid coverage all come to mind for me.
I agree. And I can't help, being the old guy that I am, to think back about, in contrast to how this was during the days of the AIDS epidemic's worst times, and thinking about how people who were worried about being sick had to also be worried about whether they were going to have any access to health care, because people might lose their jobs, either because they were sick or because of discrimination, and therefore lose their health insurance and therefore not have any access to any of the health services that might be available for people with AIDS at the time. And I had friends who were working in jobs that they really should have stayed home and tried to make themselves healthy because they were trying to keep their health insurance benefits going. And the truth is, I think that while a lot of people are probably going to lose their jobs during the coming days of the coronavirus, people don't need to worry that they're going to lose all access to health care. Because they're either going to be eligible for an individual market or they're going to be eligible for a Medicaid expansion in most cases, and that they can concentrate on their health status and not have to concentrate on worrying that they're not going to be able to get access to care.
I think that's right. I was taking a look at Congress is sort of addressing the crisis in waves. And so the bill that they passed, that the president signed yesterday, it has some coverage provisions in it, but it really is focused on sort of making sure that people have access to testing and diagnosis without, having to pay out of pocket, things like that. But I was sort of reflecting on how minimal that is relative to, other crises we've faced in the past, whether it's the HIV epidemic that you're talking about or H1N1, even some of the economic downturn in 2008 and 2009, having to extend COBRA subsidies and sort of build a system. And in reality now, I think the ACA has really become that backup system where if folks are going to lose their job coverage, there is a place for them to go. Like you said, some of them are going to get a lot of help to pay for their coverage. And, you know, the goal is to get everybody back on their feet. But in the meantime, you sort of have this, you know, safety net that's there. But again, I was remarking that Congress could have done more in that bill, which we could probably talk about to improve coverage. But the idea that they didn't have to go in and make broad scale changes, they could focus on things like paid sick leave and other protections for people, because in many ways, I think some of the major dysfunctions, not all, but many of the major dysfunctions of the health coverage system were addressed by the ACA. I don't know if that maybe says too much or proves too much, but it's something I was reflecting on.
Well, I'm sure that the coming days of coronavirus are going to show us the flaws that still remain in the system.
Right.
But having said that, there is, in its most basic sense, a safety net for most people. Now, again, we're going to talk later about people who live in non-expansion states and Medicaid, and boy, the Medicaid program has not been extended. But for people in 2/3 of the states, there's a structure in place that allows them to keep access to basic healthcare services, even as the pandemic and as the economy go in ways that we had never expected.
That's right. And I guess maybe one more thing from me on coronavirus, which we could talk about for the entirety of our time together, Tim, but I will say I have been somewhat frustrated by the response from the Trump administration, but particularly around, you know, I specialize in private health insurance. And so feeling like, you know, there is more that they can do to kind of leverage the authority that they have and push harder and make sure that folks are actually getting the coverage that they need in this emergency time. You have, you know, Secretary Azar declared a public health emergency relatively quickly, actually. But then we sort of spent some time waiting for President Trump to declare an emergency under the Stafford Act, which really unleashes all these federal powers. I know I'm spending some time thinking through, you know, what can HHS or the administration do, even without Congress, things like, at a minimum, opening up a special enrollment period so that folks who don't have coverage now could go to healthcare.gov and just sign up and make sure they have coverage in place. We're seeing a lot more leadership, frankly, from states on some of these issues than the Trump administration at the moment. And so I'm hoping that maybe they're waiting on Congress, but there's a lot more I think they could be doing, at least with respect to private health insurance.
Which brings us back to another portion of what we were going to talk about, which is, let's talk about the structure of the Affordable Care Act and how we got here. It is a monument. It is a 10th anniversary. And there are some things that are just remarkable about it that I think we should note in passing, even before we start into, and we should fix this, and we should fix that. I think one of the most important and most remarkable pieces in the basic structure of the ACA, and I would think this, it's one I spent a lot of time working on when I was a Hill staff person there, is the availability of preventive health service benefits without cost sharing to the vast majority of Americans automatically. That as soon as it is recommended for a group of people, then it is suddenly covered without any cost sharing for people in the first place. So as we are thinking about coronavirus right now, and everybody focusing on, okay, when's there going to be a vaccine? I think, oh yeah, and in the past we had to worry about how we were going to get people access to that vaccine. Whereas under the Affordable Care Act with the Preventive Health Services benefit, that is going to take place just as one step follows the next, without any intervening legislation and without any intervening action by the executive branch. So that's one of the things I look back on and say, you know, this is really going to help with the coronavirus, this aspect of the ACA.
No, that's exactly right. And Tim is, for those watching, Tim is being very modest. He was the mastermind behind this incredibly important provision in the ACA that is, I think, one of the best examples, or one I certainly always point to, of true evidence-based public health policymaking, which we don't always see, unfortunately. And Tim, that has been, I think, a hallmark of your career. But I would especially point to this provision. 137 million Americans have gotten free preventive services that are evidence-based because this was included in the ACA. Maybe more now. That's a number from 2015, so I'm sure it's even higher now.
Yeah, I'm sure it's even higher now. And God willing, when we have a corona vaccine, that we're immediately going to have access for all, or almost all, Americans to this without any cost sharing that might interfere with their ability to get it. The other thing that is most remarkable to me, and then I'll promise I'll pass it over to you, is the availability of Medicaid regardless of people's category. Now, we know that this is something that's limited by state choice, and we'll talk a little bit about the legal aspects of that. But for decades, the Medicaid program was limited to people who were poor and something else. Poor and pregnant, or poor and a kid, or poor and over the age of 65. And really, during the AIDS epidemic, that was one of the principal hurdles to getting people with HIV infection access to the drugs when we finally had drugs that were useful. But now, because of the Medicaid expansion, it's available to everybody who is low income. Everybody under 138% of poverty in those states that have chosen to expand. And that aspect is truly what Katie was describing a moment ago. It is a safety net for some of the most vulnerable people in the country.
No, I completely agree. And I think the impact of Medicaid expansion beyond coverage for those people has been an economic boon for states. I mentioned this already, but the role in supporting the healthcare system itself and keeping rural hospitals open, I think especially in states that have not expanded their Medicaid program, as we're both alluding to, the 14 states that have yet to do so, you are seeing many hospitals close their doors, especially in rural areas. And at a moment like this, for me, those states that haven't done that, you've got to think they're hopefully looking at Medicaid expansion. Politically, maybe that's still a challenge, but if ever there was a time to make sure you're sort of supporting your healthcare system with federal dollars, funded mostly by the federal government, 90% of this is funded by the federal government. This seems like quite an opportune moment to get it done. So I think it's worth keeping an eye on those 14 states that haven't expanded yet, including some high population states like Georgia and Texas, where the vast majority, in Florida, where the vast majority of folks who are still uninsured in the entire United States are living. So I think that's exactly right.
And I have to say also that the Medicaid expansion helps us make some slow but obvious inroads into healthcare disparities for not just low-income populations, but racial and ethnic minorities, people who've traditionally been underinsured or uninsured. And that too is a part of the safety net here, is that we're treating everybody with access. And that as we move into the coronavirus treatment phase, God willing, that we will be able to provide services to people in that fashion. So I assume that not everybody is as focused on low-income poverty programs as I am on Medicaid, but that some people are thinking about, okay, the ACA really is a private health insurance vehicle as well. So Katie, how has the ACA improved access for people with private health insurance?
Yeah, great question. The short answer is dramatically. The ACA was very much focused on, I think, the individual and small group market, so the coverage for small employers, but it did extend a number of really important protections to large employers, to what we call the group market as well. One of those is that preventive services provision that we were talking about earlier that applies to the vast majority of private health insurance plans in the country. When I think about what the ACA's impact on the private side, I really think about a paradigm shift from where we were certainly in 2009 and 2010 when the law was passed, but even since 2014 when many of the major reforms kicked in. So, the law banned discrimination against people with pre-existing medical conditions. And that was not anywhere close to true in the vast majority of states before the ACA kicked in. And now, just after, I think, 6 years, it's almost a third rail. The idea, every politician is out there saying we support protections for people with pre-existing conditions. It has really, I think, transformed how we think about private health insurance. Folks forget about the kind of wild, wild west days of coverage when you could be excluded and turned away and charged more. And we don't have that anymore. And, you know, you think about a crisis like this and how important and critical it is for folks to know they can go get the screening, the testing, the treatment they need without fear that they're going to lose their coverage later. I think it's a really strong analogy, Tim, you made back to the HIV crisis too, of this is one less thing folks have to worry about because these protections are in place. Other provisions I would focus on would just be making sure that coverage is much more comprehensive than it used to be. So coverage of what we call the essential health benefits package. So, you know, at least in the individual market, services like maternity coverage, prescription drugs, mental health and substance use services, none of that was covered. And now you have this sort of core, you know, benefit package that must be covered by everyone, or by most plans, at least in the individual and small group market, that we need as we think about some of the other public health crises we're facing in the country, that has just expanded access in a brand new way. And then the last thing I would sort of flag, there's a ton of private health insurance provisions in the ACA, but is really what we call the kind of annual out-of-pocket maximum. And so this is the idea that if you'll pay your premiums, if you do get sick, the amount that you're going to have to pay out of pocket, at least for covered services in your network, is capped. And I think the idea there is folks shouldn't be paying catastrophic costs anymore. You shouldn't be paying hundreds of thousands of dollars just because you happen to be the person who came down with cancer or who had a heart attack. I think it's this recognition that for the financial security of millions of Americans, we have to cap some of these costs and protect people against catastrophic costs. So for 2020, for instance, that out-of-pocket maximum is about a little bit over $8,000 for an individual and about $16,000 for a family. I acknowledge those are very big numbers, but for someone who comes down who has a diagnosis or needs treatment, the idea that that would be the maximum liability that you'd have, I think just keeps people from going into bankruptcy over medical bills and things like that. So really bolstering, I think, the economic security of millions of Americans as well.
I agree that the out-of-pocket maximum, being able to be sure that this is the maximum exposure you're going to have as long as you stay within your network and within covered benefits, is one of the most reassuring aspects of the Affordable Care Act's insurance reforms. Another one that I would point out to people if they don't know is the elimination of the old practice. It doesn't seem possible now, but the old practice of saying that an insurance plan would only pay for so much money during any 1 year, or would only pay for so much money during anybody's lifetime, so that the insurance policy had a limited value. And now with the elimination of with the capping of out-of-pocket maximums, and with the creation of no annual limits or lifetime limits, plus no pre-existing condition exclusions for getting there in the first place, insurance is genuinely available and genuinely reliably worthwhile. That it will continue to provide services to people no matter how sick they may be.
That's right.
So we've talked for a while now about the ACA's virtues and how it's going to help us in the pandemic. I do think that we have to acknowledge that there's some things that the ACA has not done and that are continuing problems in the healthcare system. Having said that, we have to acknowledge that the Medicaid program as it exists now, with state-by-state choice, was not a policy choice. When it was originally enacted by the Congress, the Affordable Care Act required states to take part in expanding Medicaid to everybody who was low income. But almost immediately, as Katie can discuss, people who were opposed to the Affordable Care Act went to court and tried to get the court to do something that the Congress had not done, which was to limit the reach of the Medicaid program. I don't think any of us who watch Medicaid expected the court to intrude into this area. I think everyone thought that the major part of this litigation was about the individual mandate for private health insurance. But what the court did instead was to say, this is too far. Congress can't require states to do things in this way. This is what the federalism discussion of states get to make their own policy and the federal government gets to help them is all about. And the result is that the Supreme Court declared that the decision to expand Medicaid, while the feds could continue to support it and encourage it. The decision of whether to expand it to all people under poverty was up to the states. And that has meant that we continue with the patchwork quilt of eligibility in about a third of the states. I think a lot of people during the coronavirus right now are looking at that and saying, this just exhibits, just crystallizes why it makes sense for every state to expand Medicaid to reach all low-income people. But the states have been slowly adopting and coming into place. That some states that you wouldn't have expected to expand Medicaid if they were left to their own politics have begun to do so, that they've actually seen the economic and business case for expanding Medicaid, as well as the humanitarian and healthcare case. And I think as hard as it is to say that the Supreme Court made it optional, I think a lot of the states that had previously chosen not to exercise that option will ultimately end up doing so. But the thing that case, as I say, it was a sleeper issue, the Medicaid expansion in that case. The thing that case is best known for is the question of whether the Congress can require people to have health insurance or not, the so-called individual mandate. Katie, can you talk to us about the individual mandate and the NFIB case?
Sure. So this part of the NFIB case feels quaint to talk about the individual mandate, in part because it really hasn't been in effect since 2019 and has a complicated history that we'll talk about and is influencing other litigation these days. But there was this real question, I think, when the ACA was being debated and passed, of whether Congress could require or incentivize, as it may be, an individual to sort of buy a private product under the penalty of law. And so that was kind of the fundamental question. There were many debates among legal scholars about whether this was appropriate under the Commerce Clause, things like that. And the Chief Justice of the court, John Roberts at the time in 2012, concluded that it is too far for Congress to require people to be active in health insurance, to go in and purchase a product that they might not otherwise want to purchase. That is, unconstitutional. We wouldn't, sort of compared it to being required to purchase broccoli and all these other, creative analogies, if you will. But he did sort of look at this and say, even though it's called a penalty for not getting health insurance, this sort of looks, talks, and walks like a tax. And so he sort of, in the alternative, upheld the individual mandate as constitutional under Congress's ability to tax. So the idea here is Congress, passes laws to incentivize all kinds of behavior all the time. If you do it, maybe you get some sort of tax relief. If you don't, you pay a tax penalty. That's exactly what Congress is doing here. If you don't have health insurance, you might pay a little bit of a penalty on your taxes. And that is something, reasonable and completely within Congress's authority to tax. That was sort of the end of it for many years until you get to 2017, when Congress sort of zeroed out that individual mandate penalty. It was $695 and they changed it to zero. And what that has led to is a renewed challenge that will be before the Supreme Court next year, or sort of, in the next term of the court, over whether that is still a tax. And, I think it's a push by the Attorney General of Texas and the other states who have brought this challenge to really try to revisit that NFIB decision and see if the same holding that Chief Justice Roberts made about whether this is a tax can be put in place, even if it's $0 right now.
So I think that's a very clear explanation of a very unclear, complicated piece of litigation and legislation. But the sum and substance of it is that we're expecting another major Supreme Court case next year of Texas v. US, talking about whether, now that it's a zero tax, whether there's anything left that can be used as an individual mandate. But there's another issue to that, not just the issue of the mandate, but an issue of whether the entire system is going to be pulled apart at this point, and everything that we've been talking about helping us at this point might actually fall to the ground. Katie, why would that be?
That's a great question. So, at this point, I think reasonable minds could disagree, and we could have the debate in, our classrooms at Georgetown Law about whether a mandate without a penalty is still a tax. Folks could argue that. I think what makes this case so scary and extreme in many ways is that the argument is that penalty, that mandate, is so essential to the entire rest of the ACA, all 1,000 pages of the law, that if the mandate is struck down as unconstitutional because it is no longer a tax, the entire rest of the ACA should also be invalidated. And we tend to think, you and I have already touched on all the different components of the ACA, but folks do tend to think of it very narrowly. They think of the healthcare.gov and protections for people with pre-existing conditions. This would go much broader. This would strike down the closing of the Medicare drug donut hole, of the Prevention and Public Health Fund. It would, the ability of the FDA to approve biosimilars, the Medicaid expansion. It would really sort of take this law that has really been baked into the fabric of the American healthcare system for the past 10 years that it's been in effect, and try to wipe it away using sort of this idea of judicial repeal of the law. And so that is what makes the case. Again, the individual mandate, is it a tax, is it not? Reasonable minds could disagree, but the idea that the rest of the law, or even major portions of the law, even if not the entire thing, could be struck down, makes it just introduces so much uncertainty for health insurance companies and providers and state and federal officials and consumers and patients and folks who have come to rely on this and made decisions over it. And I would add, it sounds like a far-fetched opinion or a far-fetched argument, because it is, but you already have a district court that has agreed with it. So you have one court in Texas that has said, yes, the entire ACA should be invalidated. That has gone up to appeal to the Fifth Circuit Court of Appeals, which is generally thought of as the most conservative appellate court in the country. And they agreed that the mandate was unconstitutional, but sort of punted on that question of whether the rest of the law should be upheld or not. And that is the decision that is now sitting before the Supreme Court that we'll hear, we'll get maybe a little bit more guidance on, likely a decision in 2021. But, that it's the idea that you could wipe away a law so significant after it's been in place for 10 years because of the court decision, I think is, and I would add, after Congress spent all of 2017 trying to repeal the law and could not do so, to me is outrageous.
When I talk to people about this case, and people know that the individual mandate may or may not be unconstitutional to require people to purchase health insurance if they don't have it, people are genuinely stunned when I talk to them about this could end up pulling down the Medicaid expansion. It could end up pulling down Medicare improvements in preventive services. It could end up pulling down all of the insurance reforms, like no pre-existing conditions or no annual caps or out-of-pocket maximums. It could pull down all of those things at once. And people are saying, wait, I don't understand. How can that be? We were only talking about the question of whether I can be required to eat broccoli. And I'm saying, yeah, but the way that the court has put this decision together and said everything falls if anything falls means that the entire system is at risk. I can only hope at this moment that we're talking about this today that the necessity of having many of these portions of the ACA has been brought home to people with the coronavirus in a way that we knew was true for a lot of people who had serious and chronic illnesses in the past, but is now true for everyone as we face this. And I can only hope that the justices along the way, as they look at the doctrine of severability, of whether everything falls if anything falls, will take into account that some of these things have, as you say, been baked into the system. In addition to the judicial challenges, this major judicial challenge, and I know what I think I've heard you say 50 other cases that you're following at any one time, there are political questions coming now, also electoral political questions about whether the ACA survives in its current incarnation or gets dramatically changed one way or t'other. I need to begin, as the old guy who actually worked on trying to get a minimum number of votes on this statute by saying we did settle on relying on current health insurance systems, private health insurance systems, and current Medicare and Medicaid programs, and building on top of those. We did not start over with a new health insurance system. But many Democratic voters these days in the primaries seem to be suggesting that they would like us to start over with whatever it may be called, Medicare for all, or a single payer system of some sort. I think that a lot of health policy people and health lawyers would say, oh yeah, it would be so much easier if you just started from scratch. And yet, I have to say, a lot of political people and policy people are saying, you know, we barely got through the incremental reforms of the ACA. It's going to be very difficult to be able to start from scratch with a single payer system. So the impact of the election this coming November will be a dramatic question of whether we can start over or whether we continue to improve the ACA as it stands. There also, of course, is the possibility that it could get worse because the current administration is trying to undermine the ACA from within without actually being able to get the Congress to vote to so-called repeal and replace, or in some cases just repeal. What kinds of things do you see as the challenges of the Trump administration to the ACA without getting a vote from Congress about it?
I will say the Trump administration has already done a lot to sort of undermine the ACA, as you're mentioning. So it would, I'm sure there could be many more things in sort of a second-term Trump administration that could be done. But you know, they've already done things like half the open enrollment period so that folks have less time, dramatically cut funding and for advertising and outreach. They have really sort of taken advantage of loopholes to the ACA that Congress or others wouldn't fix at the moment to expand basically access to all types of plans that don't have to meet those really important consumer protections that you and I were talking about at the top of the of our chat. And so they're doing a lot. I think if you want to know what they would like to do, I would, you know, focus people on the budget proposals that the Trump administration has consistently put out. And I think especially too, we're going to see a lot more on Medicaid, as Tim knows. So things like block granting, where you're just sort of giving a lump sum of amount to the states. Critics of that would say it's not going to cover, and you're going to end up having cuts to services and eligibility, you know, populations and that kind of thing. I think there is I think a lot of this is driven by sort of ideology. And so I think a second-term Trump administration might push even further than they have. And some of the things they've already done, even when you think about public charge rule, some of the efforts to discourage immigrants from getting coverage, provider conscience, you know, really elevating those who have religious objections, whether it's to birth control or, you know, providing certain services. I think all of those would be things that I would watch. But, you know, one challenge that I think we've had is President Trump and all the way down sort of says we're here to protect people with pre-existing conditions. And you look at sort of the position they've taken in this big Texas lawsuit, you look at some of the policies that they've unveiled, and that is, you know, patently untrue. And, you know, we could all sort of argue or discuss where the Democratic Party is. And if you know, watch the primary, which policy should they take on? I think I'm very confident that no matter what Democrat or no matter what policy is sort of being debated more towards the left, it is going to be a clear contrast with President Trump in a general election. So I think there's been a ton of focus on kind of the Democratic primary, and it is your question, Tim, do we go really big? Do folks really want to, you know, throw the table and upend the system, or do we really build and try to work on what we've got? Comparing that to where President Trump has been for the past, you know, 4 years is going to be a very clear contrast in my mind.
Which is not to say, we need to be clear about this, that the ACA has solved all of our healthcare and health access problems. Right. I think people are particularly frustrated with the rising cost of prescription drugs. and how much that is adding to both the bills of the insurance companies, but also adding to the bills of the people who are not adequately insured. I think also people are surprised at the evolution of the healthcare system, which I think probably would have happened regardless of the ACA, into depending so much on networks and then being surprised when you actually get your healthcare services out of network, even though you were trying to be in network at the time. And so surprise medical billing, I think, has continued to be, has grown to be a major concern for people who no longer have to worry about whether they have health insurance or not, but are now worried about whether their health insurance is actually going to cover the services that they get. And that both very expensive pharmaceuticals and surprise medical bills outside of your network will continue to drive people to say, this isn't enough. And the question has to be, do we try to incrementally improve that? And deal with prescription drug pricing and deal with out-of-network costs, or do we, as you say, turn over the table and start over again? And I think that this will be a very important election for those questions, but I think we also have to recognize that the healthcare insurance debate is far from over.
For better or worse, I think that's right. And, one last point on that, polling data sort of across party, across partisan line, including independents, it really does show exactly what you're talking about, that folks care more about these pocketbook issues. I think the Medicare for all versus something else has very much animated the primary, but when you look at what people want Congress to do, frankly, it is to address these surprise medical bills, to lower prescription drugs, it's to take on really, really high out-of-pocket costs that people just simply can't afford right now. And I think to take it back to the coronavirus crisis, I think, having high deductibles and having to pay out-of-pocket costs for care is something that millions of families are probably worried about. So I think some of the debates about coverage and how you get it and what it looks like and where you get it from, I think are going to continue, but the polling data is pretty consistent. Folks care about their wallet and how much they're paying for healthcare.
So I think what we have to say in conclusion for this discussion is that it is a very interesting and important time to be celebrating the 10th anniversary of the ACA. When we first scheduled that we would do this, no one could have predicted that we would be in the middle of a situation in which health and public health was so central to everything that the nation is about. But what I think we have established with this discussion and will continue to see is that without the ACA having been enacted 10 years ago, we would right now be in a much worse situation than we are now. That everything from the Medicaid expansion to the improvement of services to Medicare beneficiaries to the availability of private health insurance, regardless of whether you keep your job or not, to my special favorite of the availability of preventive services without cost sharing. All of those things are making it possible for us to respond as a nation to coronavirus much better than we would have absent the ACA. There are things that still need to be improved. We know that. There are bridges that still need to be passed in litigation and legislation and elections, and we know that. But one thing we know is that the ACA has made what is happening now a little more bearable than it would have been without it. Katie, do you have last words that you'd like to add about the ACA and our anniversary or the coronavirus or where we're headed?
No, I think there's a lot more to come. I echo your sentiment. I'm so grateful that this law is in place and there to help. And Tim, I would just give an extra special thank you for, it's as much your anniversary as anyone's, I think, given all the work that you did and the leadership that you showed working with Congressman Waxman and many others. It's incredible, the impact that it's had, and it's so important. So thank you for everything you've done on that and many other of the initiatives you've worked on over the years.
Well, you're very kind. And I'm happy also to say that I don't think anybody would have understood what is currently going on without your ongoing work in health affairs, where all of us turn to try to understand what is happening and what does it mean. And for that, we look for Katie Keith. So this is Georgetown Law School. And come join us for video chats, or come join us for meetings if we ever have meetings again. Come join us for education, and you'll have discussions like this on health law on a regular basis. Thanks.
Thanks.